So I'll do a bit of an introduction of myself and our program. And one of the main reasons I'm here is I really would like to network with people. I feel like one thing the field really needs is large multi-site studies, and that takes collaborations around the country. But about me, my name is Bill Marchand. I am a psychiatrist by training. I work at the VA Salt Lake City healthcare system in the whole health service, which you probably, what is whole health? Well, it's a model of care based on disease prevention, health promotion, and the utilization of complementary and integrative health care. So within that program, we built our equine-assisted services program. But a little bit more about me. I have a strong background. I've been a psychiatrist in the VA for many years. I was a psychiatrist on active duty in the Air Force. Much of my career has been in federal service. So I am a veteran myself. I'm a horse person. I'm a PATH EAS, and I'm also EGALA certified. I have a horse myself named Goldie. If you want to hear more about the horse.
We all want to hear more about the horse.
Forget the intervention. Let's just talk about the horse.
Goldie, Palomino. I mean,
Sorrel. Anyway, so about 3 years ago at our VA, we decided to implement an equine-assisted services program. And I think what we do is a little bit different because I think around the country, oftentimes the equine facilities are not part of the VA. And so I hear a lot of challenges from people who are outside trying to work with the VA. And so the way our program works, we have community partners. We're affiliated with Utah State University. They have an equine and human science program. And also with a place called National Ability Center, which is a nonprofit that has an equine program. And then I also work with a private stable. And so our model is one that we start within the VA. We get consults from various clinicians, or veterans can self-refer. We take veterans who are enrolled in our residential substance abuse program twice a week for psychotherapy incorporating horses and EAL. And then we do work with outpatients in a couple different models. We use the EGALA model. And then I also have a model that's based on mindfulness and self-compassion. Just acknowledging all the folks who worked on the study that I'm going to talk about. And I'm going to segue. Our program is a collaboration between our whole health service and our mental health service and community partners. And we have a strong research component. That's the other piece of it. We really feel like to move the field forward, we really have to do research. And we focus particularly on suicide prevention, PTSD, and substance use disorders. But any enrolled veteran is eligible to participate. And most of this stuff is what I was already telling you, so I'm not gonna. So, the study. And at the end, if anyone wants to hear more about the program or catch me afterward, I'd love to brag about it. So, the study was approved by the University of Utah IRB and the other appropriate agencies, including the IACOC at the Utah State University. And it's a prospective, uncontrolled trial, so it's basically a pilot study, mostly aimed at feasibility and safety of this intervention. But we also do have some interesting outcome findings. And really the idea of this was that this was developed as an intervention that could be imported to other sites or easily replicated for more rigorous studies. As we all know, one of the challenges in the field right now is that there are probably 50 million different interventions out there. and that makes it really hard to do any kind of comparison work. This was developed by Utah State University. I wasn't really involved much in the development of the intervention, but I was a study PI, and I'll say more about the intervention, but just the idea is that we want to address gaps in the literature, get preliminary outcomes, and then particularly see if this model intervention was something that had merit to do more rigorous studies with. So it was a small sample. That seems to be a common thread throughout this presentation. We ended up with 18 veterans. 21 were enrolled, but 3 dropped out before completing session 1. The participants in here all attended at least one session, and the mean age was about 46, with a range of 28 to 69. All had a military-related disability. That was not an enrollment criteria. I'll also just say that part of the learning here, as some other people said yesterday, is that how hard these particular studies are to do. And we were also impacted by COVID. This happened during COVID. We did it a year later than we intended, primarily because of that. And we were actually going to do a randomized controlled trial, but we realized that we weren't going to be able to do that. So we ended up just doing an open study like this. I see some heads shaking out there. The main problem, excuse me, was recruitment in the time frame. Because we were working with Utah State and they had a class schedule, we had to get it done within a few months. And so we didn't want to put it off another year. Most subjects, they all had PTSD. Most had psychiatric and medical comorbidity. Over half had a co-occurring mood disorder, and most common medical conditions were chronic pain, hypertension, and sleep apnea. So this was a fairly sick group, and remember they all had military-related disability. So one of the questions, can you actually do this with a group of veterans who have quite a bit of psychiatric and medical illness? I mentioned earlier it was a horsemanship skills training program developed by Utah State University by Judy Smith, who some of you might know, and Dr. Carl Hoops, who's a veterinarian. And so an important point here, we were using this for psychiatric illness, but there was no mental health component to it. So that was one of the questions, because in the field, again, it seems unclear, how much does the psychotherapy piece do? How much does the horse piece do? How much does riding do? How much does groundwork do? We can study this stuff for 100 years to sort all this out. Anyway, it was designed to be a horsemanship skills intervention. There were 4 sessions conducted over 4 consecutive weeks. Sessions 1 and 2 were at the Utah State University Equine Facility in indoor and outdoor arenas, and sessions 3 and 4 were conducted at a mountain riding trail. So the first 2 sessions had groundwork, horsemanship skills, riding in an arena, and the second 2 sessions were actually trail rides. Sessions 1 and 2 were very experiential, and in addition to basic equine handling skills and mounted skills, they were really also focused on horse-human relationships and equine behavior. The trail rides on the last 2 sessions were about 45 minutes, but we were there for a couple of hours between briefing and debriefing and lunch. We did a whole bunch of stuff to mitigate risk in this population. Everything was conducted according to PATH standards. So, what did we try to measure? Well, we wanted to know if it was safe and feasible. So we looked for any adverse events for horses, staff, or participants. And we wanted to know if it was feasible, could we actually pull this off? And then was it acceptable? Did the veterans like it? And did they actually attend? And we used the PTSD checklist, PCL-5, Vet Depression Inventory, a quality of life scale, the acceptance and action questionnaire, which measures psychological flexibility, the positive negative affect scale, and the physical activity enjoyment scale. And then we did a number of statistics. I'm not a statistician, so I'm not going to say a lot about that. If you have questions about the stats, don't ask me.
Good answer.
Yes, ask that gentleman the other bill. So, was it feasible and acceptable to the veterans? Sort of. It took a lot of staff to do this. And again, I didn't design the intervention. I think we learned a lot about it, but we were able to pull it off because basically Utah State University has a lot of students, and this really took a lot of staff manpower and taking the horses out to the trailhead, getting the veterans there, recruiting. So it is feasible, but probably only in some limited locations where there's really strong, large equine facility like this one, for example. So we really wondered, well, will the veterans actually come? And they had to drive themselves quite a ways, and many of them came from the Salt Lake Valley, which is about an hour and a half from Utah State. So they had to put some effort into it. And the mean number of sessions attended was a little over 3, out of 3 or 4 possible. The reason I say 3 or 4 possible, one session got canceled because of the weather towards the end, one of the trail rides. So the final cohort only had 3 sessions. But actually the attendance was pretty good compared to some of our other research. Whereas we find with a lot of stuff, we find about 50% attendance from veterans. And these are all MVA offered services. And 11 veterans attended all sessions, and 94% attended at least 2. So we actually thought that was pretty darn good. So the takeaway there, it was pretty hard to implement. It probably couldn't be done everywhere, but the veterans attended. The PACES measures, it's a physical activity enjoyment scale. And so the average was 109, and I think the max can be like 128. So they really enjoyed it. So I think it says maybe in general about the field too, that these interventions probably do have something for engagement for veterans. And that was mentioned yesterday as well. There were no injuries or close calls. So that was good. And we didn't see the psychological instruments were done pre to post session as well as pre to post intervention. And there was no worsening of like anxiety or depression pre to post session, so that was good. But one veteran became really anxious on the trail ride, and to the point that she was in significant distress. She completed the ride and actually went ahead and did the second one, and has done some other equine stuff with me since. But I think it does point out that when you're working with a psychologically challenged population, particularly with people with PTSD and anxiety, that there is a risk of putting them on a horse that they can get incredibly anxious. And I'm not sure, I mean, I knew that, but this really brought it home, and we actually changed what we were doing a little bit in the process of the study. I would meet with each veteran individually before the ride and just make sure that they were actually feeling okay about it. And a couple of others expressed some anxiety as well. I think a mistake we made was that the ride was on some ground that wasn't level. It had some ups and downs. And for people who are new riders and have anxiety to begin with, that's probably not where you want to go. But again, it was a learning process. So the short-term outcomes, again, this was pre to post of each individual session. And we found increased psychological flexibility, increased positive affect, and decreased negative affect. And all of these had fairly large effect sizes. Again, we were discussion of p-value yesterday. Well, they were significant, but does that actually mean anything? How much time do I have?
10.
Okay. Does it actually do anything clinically? And again, I'm not a statistician, but my take is the larger effect sizes do mean it probably does have the potential to make a clinical difference. So these were the short-term pre-session, post-session. And this is consistent with some of our other studies as well. And here's the table. I'm not going to belabor that. It's probably pretty small for you guys to see anyway. So, pre to post intervention. So this was right before the first session until right after the final session. Again, we saw consistent increased psychological flexibility. And psychological flexibility is an interesting construct. It's highly related to resilience, and it's kind of what you would think. Instead of having a very rigid thinking process of black and white, it is able to be more flexible in your thinking, see things from multiple perspectives, think of ways to problem solve rather than being stuck in, oh, this is awful. So we think psychological flexibility is a construct that probably should be studied in the field because we found this in a number of other studies. There were decreased PTSD symptoms, improved affect remained. We used the Beck Depression Inventory as well. No change there and no change in quality of life. And again, medium to large effect sizes. And finally, we did 30-day post-study measures. Now, this is a smaller sample size because we couldn't get all the veterans to do this, which is not uncommon. But 30 days post, which could indicate, a longer-term persistence of change. We did see continued increased psychological flexibility from immediate pre-study. Decreased PTSD symptoms still, decreased depressive symptoms here on the BDI, but still no change in quality of life, and no persistent changes in short-term affect panels. So we had some preliminary evidence of long-term 30-day changes. So with all that, the discussion conclusion section is it was generally feasible, but again, not probably in many places, and there definitely should be some changes to the intervention before it was implemented again or used in another study. It was safe, and the veterans enjoyed it. Might not be acceptable to veterans in other geographic locations. This was just done in Utah. We felt like the safety risk can be mitigated to use mounted work. I'm sure that's not a surprise to most of you. So we did find preliminary evidence of increased psychological flexibility, improvement in affect, symptoms of depression, and PTSD. But this is where we get in the limitation section. This was not a randomized controlled trial. There were many limitations. There's selection bias because of the way we did recruiting and we didn't randomize. Again, because there wasn't a control group, there wasn't a randomization, we can't say this was cause and effect. Maybe all of the veterans changed their antidepressant during the time or something else. And so that's why they improved. And I think, the bottom line take home is that really rigorous studies of this and other interventions is what the field needs to move it forward. So we did find some implications for the larger field though. And again, I mentioned at the beginning that this was not in any way a psychotherapy intervention. I was there all the time, and on the rides and groundwork. But the only thing that I did, I was the only mental health professional there. The only thing that I did was just check in with the veterans before the rides. I didn't do anything that would be remotely counseling. Now it's possible just being in my presence. I'm joking. They did know that I was a mental health professional, but we didn't do anything mental healthy at all, and we found these changes. It doesn't prove anything, but it does start to suggest that there really is something about the horse that helps mental health. Now, it's not a big surprise to anybody. I think we all believe that, but there's not a huge amount of evidence for it. So I do think future studies of interventions that for mental health that don't include psychotherapy are certainly warranted. And now, the next great study would actually be to add a real psychotherapy component to this and see if we see more difference. Another question in the field is, what's an adequate dose? And there was some conversation about that yesterday with some different groups saying different things. So this was 4 sessions. Again, very preliminary results, but maybe 4 sessions is enough. Ultimately, we need to figure out a way to assess participants, veterans or otherwise, and determine what the best intervention is and what the correct dose is for that veteran. But that's a long ways down the road. But we found evidence for 4 sessions, and maybe mounted work provides equal benefit to groundwork. We published another study not too long ago of recreational trail riding alone, again without any mental health intervention, and it saw similar short-term changes. We did look at long-term changes in that group. Here, the pre to post changes were pretty similar across the board, so the mounted work resulted in about the same short-term changes as the groundwork. So, again, just another little piece of information to add. I already talked mostly about the limitations. So I think we'd like to trial this model again. It would be nice to do much more rigorous work with it and see if what we found holds up. And I think I've got like 2 minutes left for questions, comments, or throwing rotten tomatoes, whatever you'd like to do.
Is this Goldie? Is that Goldie?
Thank you. No, that's not Goldie. It looks like him, but that's just a random picture.
Did you? Oh, I'm sorry.
That's really interesting, Bill, thanks. At one point you said that there was a focus on equine behavior and human-horse interactions, and what does that mean?
Okay, good question. So the USU folks are very, very focused on this, and so, there wasn't a huge amount, but part of the session 1 and 2 were really talking about equine communication, body language and that sort of thing, signs of stress, etc. They did some liberty work with the horses. So they were trying to come at it from not just a basic horsemanship, but there wasn't a huge amount of that.
Okay, thanks.
And did you, knowing that your participants had PTSD, did you screen for triggers prior to any offering any services?
That's a great question. We did not specifically do that. I did talk to all the veterans about what we were going to do and ask them, if they were comfortable, and of course they signed a consent.
Mhm.
I think in retrospect, though, we probably should have done that, and I think that probably happened with the one veteran. So that's a very good question. I don't know, I'm sorry.
I have an out-of-the-box question actually for all of you. At the board level, we often talk about the so-called pharmaceutical gold standard, randomized control. And the question is that really the best model for the work that we do in this field? Or is there another way we should be coming at it?
I think that's a wonderful question, and it's been confronted a lot in the field of complementary and integrative health
Yeah.
in general.
Yeah.
And you can't do a placebo for EAS. And someone smarter than me needs to answer that question, but I think it's a really good one. Maybe other people have thoughts.
So one really simple design is referred to as a prospective multiple cohort study. So you have multiple cohorts around areas. So you have in Utah, we've heard of Slippery Rock, we've heard of different areas, Texas and Baylor and so on. And if we took the multiple cohorts, understood the characteristics of those different cohorts, found a gold standard within those cohorts, identified measures of interest that are consistent across the cohorts, and then did a prospective study. So we have a baseline measure for all of the cohorts with all of the variability in all of those different areas, and then followed them on a set of measures. So you talked about PANIS, we talked about PTSD checklist, you talked about the PTSD checklist, the multidimensional anxiety questionnaire, blah, 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 right? So we can get an entire slate of surveys. So that's our perception, the subjective response. You're a psychiatrist, you're familiar with the kind of pharmaceutical regimens that most of these guys are on. That is a major covariable that we need to think about in terms of confounding. You probably saw that, Beth, in terms of the stuff. We have to consider that in the outcome measures, and then what the drug interaction is relative to the metabolic end products that we're measuring relative to these kinds of things like oxytocin, cortisol, whether we're looking at heart rate variability again, what happens to those kinds of biomarkers as we move forward as well. But if we have enough data through enough multi-centers as opposed to randomized clinical trials, they're not great. Everybody thinks they're great because there's a lot of pharmaceutical support for those kinds of things. They're big money, but they're not great, right? Not in this, it's not a one-size-fits-all kind of model. So, but multiple cohorts, multiple centers can actually resolve that problem.
I agree with Bill on that. That's something that, especially in public health, we've moved away. You really can't do it when you're doing community interventions, and this is basically what you're talking about. Population type of interventions, you can't really do the standard randomized control trial. You can do the quasi, which is what I did. That's probably the next best one, and also what you're talking. There's a lot of things you can do, especially when you start increasing the N, because then you can start to evaluate things a little bit more stringently, consistency, and so I think what you're hearing is like several researchers going to say, what have we already done? Because I did a multi-site for 89 veterans, and we looked at the same things. We had no mental health intervention. There was somebody in the peripheral that they could go to. And we found clinically significant changes, and I had a comparison group and those going through intervention for 8 weeks. So there's some data out there that can help us to build something much, much larger. So I love your idea. And having a biostatistician involved in this too, as well as help us to think through that model, that design carefully, so that the design is critical to the outcome, because the outcome is not going to be very helpful to analyze if your design was not efficient from the beginning.
There's such a large number of centers that are offering very similar adaptive riding or EAS services in this arena. You would think with some pretty minor tweaks to the population that is already providing services, there may be an opportunity for you guys to get the data from those groups. Now there's of course a lot of additional consideration, but I think both sides of the community that are here might have some interest in that.
Well, thank
So
you
maybe-
so much, Bill. You have to stop. He's wrong.